The third lecture will be presented by Dr. Majid Khan. He's presenting hypopharyngeal tumors.
Okay, let's get started. So we will be talking about the hypopharynx now. These are my disclosures. Again, this is a special thank you to Dr. Mukherjee for sharing this with me. So we'll be talking about the technique, the anatomy a little bit, and the neoplasms and other benign conditions that involve the hypopharynx. Again, I'm not going to go over the CT. We went over it, multiplanar capabilities, and that's what we use mostly. You can do, again, monophasic or biphasic contrast injection, but we typically use the monophasic just to save some time. CT, again, primarily used for this. MR, problem-solving tool, but very important here is the involvement of the prevertebral fascia or the prevertebral muscles. PET will be used in the post-treatment settings. So just going again a little bit over the anatomy of the hypopharynx. So if you look at the external suprastructure of the hypopharynx, it extends from the hyoid bone all the way down to the inferior aspect of the cricoid cartilage. And posteriorly, it is the inferior constrictor muscle that forms the posterior wall of the hypopharynx. And if you look at the neurovascular bundle, you will have the vagus nerve and you have the glossopharyngeal nerve. And sometimes that's one of the reasons that if you have a hypopharyngeal mass, you can have referred pain and have otalgia because of the glossopharyngeal nerve also is involved here. So what are the contents in the hypopharynx? We already talked about it: piriform sinus, posterior pharyngeal wall, and the postcricoid region. Now, if we look at the anatomy overall, now on the lateral aspect, we have these pharyngoepiglottic folds that we talked about. And inferiorly, we have the inferior border of the cricoid. Posteriorly, you have the posterior pharyngeal wall. And then this is the common party wall, which we'll be talking about a little bit. This is a concept that you have to understand nicely. And here you can see medially are your aryepiglottic folds or the AE folds. And that forms the piriform sinus right there. So this is also called as the smuggler's fossa because it hides tumors early on. So it's very important that you scan it very, very nicely when you're looking for tumors, especially in this region. So these are your aryepiglottic folds, and this is the opening into the piriform sinus, which is also called the introitus of the piriform sinus. Pear-shaped structure. Apex is distal in the chordate direction. So here you see AE fold and the piriform sinus is on the side. Again, when you are at the level of the cricoarytenoid joint, one important landmark is you are at the level of the true vocal cord, but at the same time, when you see this, you are at the level of the apex of the piriform sinus. So normally you do not see that hollow air-filled cavity down there, but you have to know that this is where the apex of the piriform sinus resides. So the functions, it's a lateral channel for food. It has a very rich lymphatic network, hence always ipsilateral or ipsilateral and contralateral lymph nodes are associated with this diagnosis. And as I said, you can have some referred otalgia also with this. Posterior pharyngeal wall is primarily made up by the cricopharyngeus muscle, and that's along the back end, and in front of it is the pharyngeal mucosal space itself of the hypopharynx. Now, coming to this postcricoid region, or which is also called by some as the common party wall, and you have to just understand where exactly this is. So back here, we see this is the posterior pharyngeal wall. Then you see the sliver of lucency, which is the pharyngeal mucosal space of the hypopharynx. And then you see another band of soft tissue right here, which is just behind your cricoid cartilage, cricoid lamina. So when you're looking at this, you have cricoid lamina, you have this soft tissue stripe that is behind the cricoid lamina, you have the mucosa, and then you have the posterior pharyngeal wall. So to say, the anterior wall of the mucosal space is your postcricoid region, or the common party wall that we call as. So it just divides it into two areas. Coming to the neoplasms that are involved, here 9 out of 10 cancers that we are going to see, probably 9.5 out of 10 cancers that you're going to see in the hypopharynx, of course, would be squamous cell carcinomas. But there are other cancers that you can also see. We know minor salivary glands are all over the pharyngeal mucosal space, so hence adenoid cystic carcinomas can be seen, lymphomas can be seen, sarcomas, as there is inferior constrictor muscle and other muscles around. This is an example of a rhabdomyosarcoma. This is an example of a leiomyosarcoma that you see in the hypopharynx. And of course, nerves are coming in and out, so you can have schwannomas also develop in the hypopharynx. So these are 3 different patients, and if I ask you, what do you think of these 3 patients, you might probably say there looks like a mass right at the cricoarytenoid junction. This is probably an apical piriform sinus apex cancer. This looks like a post-radiation change. There is diffuse change. There is some mucosal edema, and this, again, looks like a big blob mass. Of course, it's going to be squamous cell carcinoma that primarily involves the piriform sinus. But this turns out to be Candida, and this turned out to be TB. So it's very important not just to look at the imaging. You really have to look at your history that is being given to you, because imaging at times can be completely non-specific. So everything that you see in there is not cancer. Coming to the hypopharyngeal cancer per se, it's about 2,000 to 4,000 cases of hypopharyngeal cancers are seen in US, associated with tobacco and alcohol. And then in female, premenopausal female with iron deficiency, anemia, and esophageal web have the Plummer-Vinson syndrome, and they are more prone to develop hypopharyngeal cancer, especially of the post-cricoid type. HPV is not a big factor in hypopharyngeal cancer as it is with the oropharyngeal cancers. And then Barrett's esophagus and chronic reflux esophagitis is also thought to be a predisposing factor for development of hypopharyngeal cancers. If we are looking at the subsites, the piriform sinus is the most common site. About 85% of the hypopharyngeal cancers arise from the piriform sinus, followed by the posterior pharyngeal wall, followed by the post-cricoid region. Fortunately, hypopharyngeal cancers, as with most head and neck cancers, barring the oropharyngeal cancers, are on a downward trend in the Americas. And that is primarily because of cessation of smoking and less alcohol consumption. Okay, now let's move on to the AJCC staging, and we will base our tumors off of the staging system and evaluate how we can go from one stage to the other stage. Most of the time, unfortunately, the hypopharyngeal cancers do not present with early symptoms, so majority of the patients that you are going to see with hypopharyngeal cancers, they will be in stage 3 or stage 4 because of late presentation. So piriform sinus, as I said, is the commonest subsite where these tumors develop. So here you can see a cancer that is arising from the introitus. You can see involving of the lateral wall, the posterior wall, but it is one subsite, so it's going to be a T1 cancer. This is another hypopharyngeal cancer that is involving the piriform sinus, but again, as I said, cricoarytenoid joint, you have a mass right behind it, so you know that you are in the apex of the piriform sinus. So this is a squamous cell carcinoma of the apex of the piriform sinus, and it's very important to scan the midline lower neck when you make a diagnosis of apical cancer. And a good radiation oncologist will include the midline lower neck and treat the neck even if we don't call any lymph node in that region. And here you can see with this small cancer, there is this necrotic cystic lymph node right adjacent in the central neck at the same level. Posterior pharyngeal wall, so the cancers involving the posterior pharyngeal wall, most of the time they will cross the midline. And the importance of that is once you see the cancer crossing the midline, then when you are evaluating for your lymph nodes, you have to evaluate on both sides of the neck rather than just looking at one side. This is a good case of a proscricoid, or the common party wall squamous cell carcinoma. Again, you can see this is the posterior pharyngeal wall. This is the lumen of the pharyngeal mucosal space, and you can see the mass that is arising from this anterior or the common party wall that is hanging off of the back end of the cricoid cartilage, and you can see that it is, the cricoid cartilage, and you can see that it is destroying the cricoid cartilage from the back end. So that's the cancer that is arising from the post-cricoid region. Fortunately, these are the least common site for hypopharyngeal cancers. Now, moving on from our T1s to T2, of course, the size, but then involvement of two subsites is very important when you are evaluating your imaging. So here now you have a cancer that is involving the hypopharynx, but what is happening here that usually it wants to get out through the cricothyroid notch there, but it's a strong ligament there which does not let the cancer blow out laterally. So what happens is that the cancer is pushed more anteriorly through the cricothyroid notch and gets into the glottic larynx. So now you have a cancer that is in the hypopharynx, but it is getting into the larynx. So that is two subsites are involved, so that ups the grade. This is another example, same hypopharyngeal cancer in the piriform sinus. Again, you can see getting into the glottic larynx, and here you can see there is destruction of the thyroid cartilage also, and you can see if you compare the strap muscles on the two sides, there is more bulk to the strap muscle on the ipsilateral side, so it has blown through that cartilage also, so there is extra cartilage involvement here. This looks like it is getting into, this is the piriform sinus mass, but it has blown through the ligament there. It is involving the carotid space. And when you have involvement of the carotid space, you directly go to a 4B. So that is a non-operable state at this level, and this is a big, huge lymph node on the ipsilateral side. But what is more important is to realize that there is involvement of the carotid space here. Circumferentially, the tumor is around the carotid. This is just the MR of what we saw on CT. Here again, you can see the tumor cannot go out through here, so it is extending anteriorly through the notch, and it is getting into the larynx. And if the larynx is also fixed, that is definitely a T3 disease. And you have this partly visualized node there. So we know the neurovascular bundle comes in through the thyrohyoid membrane, as you can see right here. So you can see this tumor in the hypopharynx that is utilizing that normal weakness in the thyrohyoid membrane, and you can see that the tumor is extending through that hole outside of the larynx. So these are, again, outside of the larynx, that ups the grade, and you can have the cystic necrotic lymph node right next to it. This is perhaps the most important thing that I want you to take from this lecture is involvement of the prevertebral fascia or the prevertebral muscles. So please, whether you're doing CT, whether you're doing MR, whether you are obtaining CT and MR, which sometimes we have to do because this is one of those things that your call makes a big difference. Only call it if you are sure that there is involvement of the prevertebral fascia or the longus colli capitis muscle. If you are unsure of this, please do not call it. It's better to undercall it rather than overcall it, because if you are overcalling it, you are making the patient 4B, which is inoperable. And the other reason why I say that is that if you're making that undercall, you're not completely sure about this, they will go in, they will operate on the patient, and a good surgeon will always tug on that prevertebral fascia when they are in the operating room. If the fascia is fixed, it's involved. If they can move the fascia, prevertebral fascia is not involved, they can continue with their surgery. So you have a little bit of leeway there that the surgeon will also help you out. But if you have something like this, when you see some enhancement, when you see some signal within the longus coelicapitis muscle, that's it. It's definitely involved and you call it. But if you're not sure, undercall it rather than overcall it. Extension into the esophagus. So let's review a little bit of anatomy here. So this is at the level of the cricoid cartilage. So this is the hypopharynx proper. And if we use the emoji analogy with this, this is almost like a subdued smile at that level. Now we are going below that level, and you can see that there is some thickening of the hypopharynx, which was here. Now you're seeing that it is slightly thickened. So that is, you are at the level of the esophageal verge, the cricopharyngeal muscle. You're not into the cervical esophagus yet. So there is slight normal thickening there, which is like a good smile that you can have on an emoji. But when you get into the cervical esophagus, you can see very nicely the rounded configuration there. You can see on a scan, if you're scrolling through, you can see some stripes there in the normal esophagus also, and that gives you like the surprised emoji. So remember these things when the esophageal verge is also very important to recognize between the cervical esophagus and the hypopharynx itself. So this is again an apical cancer. You have a normal esophagus or an esophageal verge. As opposed to this, you are at the level of the cricoid cartilage. So this is the esophageal verge. This is much more thickened than that robust smile emoji. And you can see that the tumor is even getting into the cervical esophagus at that level. So you're getting into T3 there just by involvement of these structures. This is just examples of the esophageal verge. Again, you can see much more thickened than what I showed you in the normal anatomy. And this is a patient who has had some radiation, and you can see some thickening of the esophagus, circumferential thickening of the esophagus. There is some fat stranding. This is how the normal esophagus should look like. But esophagus is pretty much normal with the treatment changes, but the esophageal verge is not. This is 4A. Hypopharyngeal cancer. You can see circumferential involvement of the piriform sinus. And as you come down, you can see that it is blowing through the thyroid cartilage. It is involving the cricoid cartilage. It is getting into the strap muscles. And it is getting into the thyroid gland itself. So this makes it a 4A. The only thing that can make it a 4B is that if you call involvement of the prevertebral fascia or the longus coelicapitis muscle, if you see involvement of the carotid space, or if you see involvement of the mediastinum. So those are the three things that are very important that make the patient inoperable based on your call. So all of these things are just 4A, and they can still go and operate on this patient. As I said, that it is area that is supplied by very rich in lymphatics. So you always have to look at lymph nodes. Ipsilateral lymph node are seen in about 45% of cases, and contralateral lymphadenopathy is seen in about 10 to 15% of cases with hypopharyngeal cancers. So here, again, there is an apical mass. As I said, whenever you have an apical mass, please make sure that you scan the central lower neck, level 6, because even a small non-enlarged lymph node is suspicious given the location of your primary cancer in the hypopharynx. And we already said that if it crosses the midline, then you have to scan a bilateral neck for lymphadenopathy. Another area to look for, so here is one cancer, and you can see that there is ipsilateral node, but another area to scan when you have piriform sinus or hypopharyngeal cancers is RP lymph nodes. So here you can see this very small, non-enlarged. I don't know how well it projects, but you can see that there is some small central cystic / necrotic area that was a pathological RP level lymph node. So that's another area with this diagnosis that you should be scanning very, very carefully with this diagnosis. Moving on to infections, of course, we have retropharyngeal space infections, the abscesses. Most of the time it is seen in the pediatric population. You do not need to see normally what we associate with abscess as the peripheral wall enhancement. And you can see it's multiseptated, extending into different spaces, and typically that's how it looks like. Normal anatomy, you can have suppurative adenitis also, especially more common in children and earlier adolescents. And then you can have, very commonly, you can have the retropharyngeal edema that can also be seen in this space. This is a patient with an RP abscess that is extending or involving the danger space, which is then extending into the mediastinum and causing mediastinitis. So that's very important that you differentiate between the retropharyngeal space proper, the danger space, because you want to see the inferior extension, and that's why you have to go all the way down to the carina when you are doing your neck scan so that you don't miss any of this. Finally, congenital branchial cleft cyst, and the third and the fourth types of branchial cleft cysts, which are very uncommon, but they do have a fistulous communication with the piriform sinus, and that's why we are discussing them here. So if you have a patient with recurrent thyroiditis and you have to think about this diagnosis, especially the type 4 branchial cleft cyst, what is important here for us as radiologists is that once the surgeon goes in and they take these out, and of course they have to see if they can get the tract that is leading into the piriform sinus, because they have to take the tract out, otherwise this is going to recur again. But when they send the specimen out to the pathologist is going to read it as a branchial cleft, remnant branchial cleft, mucosa, cyst, or whatever. They will never tell you whether this is a third or the fourth type of branchial cleft cyst. But we as radiologists can really help them out, because once that diagnosis has been made, we want to see where that abscess is in relation to the neck. So if it is superiorly in the neck, that abscess, it is a type 3 branchial cleft cyst, because that follows the superior laryngeal nerve. And if it is at the level of the thyroid gland, more inferiorly in the neck, that has to be a fourth branchial cleft cyst. So even though the pathologists or the surgeons will call the branchial cleft cyst, they will not know whether this is third or fourth, but we can help them depending upon where we see that cyst in the neck. The final slide that I have is the Zenker's diverticulum. You don't really need to get a CT of the neck to evaluate it. Esophagogram will show it, and this is the uncoordinated hypopharyngeal contraction against a dysfunctional cricopharyngeus muscle, and there is herniation through the Killian's dehiscence, and you can see it, as I said, very nicely on the esophagogram. You can see the contrast-filled diverticulum in the neck. Thank you.